Good afternoon, respected chairpersons and everyone in the hall. As Dr. Arvind Bhave has presented a beautiful presentation just now, where he emphasized that osteoporotic vertebral fractures are increasing in number due to more number of elderly patients. And most of our centers have geriatric medicine facility right now where these patients present to us. So as everyone knows, osteoporosis results in decreased bone mass. The predisposition is age, gender, ethnicity, lifestyle, autoimmune disorders, and drugs. So we subject them to a DEXA bone scan, which for all patients postmenopausal beyond 65 years and men aged above 70 years. The WHO classification is below -2.5, what we consider as osteoporosis. Most of them present with pain, which is evaluated with the pain scale VAS score, and disability by the Oswestry Disability Index. The types of cement that we use in the augmentation procedures are of different viscosities, that is low, medium, high, and ultra high. Osteoporotic fractures secondary to osteoporosis are seen almost in 16% of women postmenopausal and nearly 20% of men aged above 70 years. So the treatment modalities which Sir has just shown us very eloquently can be divided into conservative, minimally invasive, and surgery depending on the neurodeficits. There are proponents who consider trying conservative management for the first 3 weeks with medicines, but there are larger proponents who would prefer early augmentation procedures mainly to prevent urinary tract infections, respiratory tract infections, and chronic pain and depression. Now going to the topic of minimally invasive percutaneous techniques. The first one would be percutaneous vertebroplasty, which was first demonstrated by Galibert and Dermond in 1984, and it was performed for vertebral body hemangiomas. It is a percutaneous technique and can be done under local anesthesia, as Sir explained that most of our elderly patients are comorbid with multiple morbidities, so local anesthesia would be a preferred modality. The method is you go and inject PMMA into the collapsed vertebral body. So the indications would be intractable, intense pain adjacent to the level of fracture, failed conservative management, pain with osteolytic lesions like metastatic, vertebral fracture with osteonecrosis. The contraindications would be bleeding diathesis, favorable response to conservative management, asymptomatic vertebral compression fractures, local or general infections, allergy to the bone cement, and tumor mass in the spinal canal. The drawbacks, the biggest would be, the commonest would be a cement leak, though not all leaks are symptomatic. But in vertebroplasty, literature has shown nearly 40% of patients presenting with symptomatic cement leak. The next would be adjacent segment vertebral fractures, which would predominantly occur due to extravasation of the cement into the disc space. The causes for the cement leak would be severe grade of fracture with cortical disruption, low viscosity of the cement where adequate time hasn't been given for the cement to set before it's being implanted, and high pressure of injection of the cement. So this is an example where the cement had to be removed from IVC. Going to the next, percutaneous kyphoplasty. It was first described by Dr. Mark Relay, an orthopedic surgeon who brought the idea of inflating a balloon inside the vertebral body, basically to restore the vertebral height. Literature has shown reduced cement leak up to 1 to 8% and better kyphotic correction. There are various implant companies which provide us the balloon kyphoplasty system in India today. So a comparison of percutaneous vertebroplasty with kyphoplasty, cement leakage, as I said, is nearly 40%, longer duration, and does not increase the vertebral body height. In kyphoplasty, the leakage is less, reported about 9%, shorter duration, increased vertebral body height, and significant displacement of the vertebrae. The only drawback would be damage to the trabecula of an already fractured vertebral body. Now going on to the vesselplasty or the implants, the first I would like to talk about is OssiFix. It is an expandable titanium mesh cage implanted into the anterior third of the vertebra. Subsequently, cement is injected into this mesh. Most of the vesseloplasties are performed bipedicular, vis-a-vis the vertebroplasty or kyphoplasty. There are studies which suggest that unipedicular are more beneficial because of decreased operating time, radiation exposure, and risk of cement leakage. So the OssiFix can be used for stable thoracolumbar vertebral fractures, also for acute, stable traumatic vertebral fractures in the young, and tumorous vertebral fractures. They require less cement as compared to kyphoplasty and vertebroplasty. They are proven to show lesser pain, improvement in kyphosis, and the future scope would be only implant without cement. Now, the next system is a spine jack system. The main principle behind the spine jack system is that it provides a 3D support to the vertebral body to increase the height. This mechanically stabilizes the vertebral body in axial compression. So the technique is the same. The implant, it's a bipedicular approach where the implant, once is in the cancellous bone, the implant is jacked up to restore the required vertebral height, and the cement is injected. So you get various dimensions of the spine jack system. Now this is a fluoroscopy image showing a bipedicular approach of the spine jack system. The next technique is a radiofrequency kyphoplasty, where we use energy of radiofrequency to hasten the cement polymerization. Cement used in this is an ultra-high viscosity cement. Now, what gives an edge of radiofrequency kyphoplasty over the rest? It does not create a cavity. Rather, it preserves the trabecular architecture, and high viscosity cement fills the canals better than the low viscosity cement. Hydraulic pressure is used at a steady pace to increase the vertebral height. It is shown to have shorter duration of procedure, risk of cement leakage is reduced, and lesser chance of post-operative fracture with effective pain reduction. The last system that I would be talking about is the Kiva vertebral compression fracture treatment system. This technique utilizes a ninitol osteocoil guide wire, which is percutaneously placed into the cancellous bone. Then deployment in the cancellous bone, over the guide wire, a PEEK implant is deployed in increments. Once the guide wire is removed, cement is injected. There is less chance of adjacent fractures, reduced back pain, and minimal symptomatic cement extravasation with the use of these implants. So this is a recent 2020 review article from China, which shows a definite increase in the vertebral height in both the kyphoplasty as well as the vesselplasty group. The kyphotic angle is significantly reduced in the vesseloplasty group. Cement leakage is significantly lesser because the usage of cement is far more less in the vesseloplasty group. And the VAS score and the ODI is almost same in all the groups. So the take-home message is the principle of vertebral augmentation includes improvement in the functionality and back pain that promotes the social life and independence of patients with osteoporotic vertebral compression fractures. Like how Dr. Arvind sir mentioned that one particular patient, multiple modalities can be used for the best outcome of the patients. Thank you.